So last but not least, I just wanted to say one thing about pulmonary hypertension is that, well, what is going to be a nice screening thing that we could do to see if someone's at risk for pulmonary hypertension or pulmonary arterial hypertension is that you can do an echo. And of course, one of the things we look at are pulmonary artery systolic pressure. And why is that? Is because of the fact that, during systole, the pulmonary valve is going to be what? Open. And that's why the pulmonary artery is going to be a direct connection to where? The right ventricle. So you could think about right ventricular systolic pressure. So when we talk about how do we get that rough estimate of what's going on if this patient's at high risk for developing pulmonary hypertension, we use Bernoulli's equation. So Bernoulli's equation one-dimensionally is going to be 4 times the tricuspid velocity squared. So you got to have some tricuspid regurgitation. And we add that to the right atrial pressure. And then why do we need velocity? Velocity is a surrogate for flow. Flow is going to be volume over time. And, why are we doing this is because we're trying to get a rough estimate of what the pulmonary artery systolic pressure is going to be. So when we talk about this, is that you need to get some values in there and you need to know what echo view you're going to be using. So when we talk about trying to get that tricuspid regurgitant velocity, you want to be in that 4-chamber apical view. Here's going to be your tricuspid valve, and you're going to use this continuous flow Doppler right here to try to get an estimate of the velocity through the tricuspid valve. And we're going to get a value in there. We need to know what right atrial pressure is, which sometimes is not that easy. If you're in the medical ICU, maybe you have a central line where the CVP could be a surrogate marker for right atrial pressure, but sometimes you don't have that value. But what we do is when we use Bernoulli equation, remember the theory behind it is that all pressures are measured in the body that are relative to atmospheric pressure. This is why we zero out before getting any pressure measurements. So when I tell you someone has a central venous pressure of 5, that means it's 5 millimeters of mercury above atmospheric pressure. So when we do Bernoulli's equation, there are 4 pressure differences we're taking into account when we want to get an estimate of the pulmonary artery pressure. It's the difference between atmospheric pressure and the superior vena cava pressure, which is the CVP. The difference between the superior vena cava pressure and the right atrial pressure, which should be essentially 0. The difference between the right atrial and right ventricle pressure, which is why we're using that Bernoulli's equation, and the difference between the right ventricle and PA pressure, which I say is 0, especially during systole when the pulmonic valve is open. So taking this theory and trying to making it practical, I just gave a simple question, which is if they tell you the CVP of the individual is 12 and they tell you the tricuspid velocity is 3, what is pulmonary artery systolic pressure? Well, whose equation are we going to use? Bernoulli's equation. What is going to be that equation? We're going to say 4. And we're going to take 4 times the what? The velocity of tricuspid regurgitation. In this case, that velocity is 3. And that's going to be 3 squared, which is going to be what? 9. 9 times 4 is going to be what? 36. 36 plus what? The right atrial pressure. And the right atrial pressure should be a surrogate for that is going to be the CVP. So it's kind of like our right atrial pressure of 12. So it's going to be 36 plus 12, which is what? 48. So that's how they'll ask you a question on your critical care boards utilizing the Bernoulli equation. With all that being said, what are going to be some of the high yield points you should get from this lecture? That we talked a lot about sliding lung. It's a great first step. Do I have a pneumothorax or not? What's going to be the most specific thing to confirm a pneumothorax beyond no lung sliding is trying to find that lung point. Easier said than done. We talked a lot about artifacts. We talked about these horizontal A lines. Remember, they could be seen with a pneumo and without a pneumo. The A lines, A for artifact, A for air. You know what I mean? And when we talk about B lines, once again, another type of artifact that we use. It's going to be these reflections off the pleura, and sometimes you have too many B lines. We talked about in the right clinical setting, if they're bilateral, think about pulmonary edema. We use the terminology hepatization, or there could be alveolar consolidation and pneumonia in the lung that makes the lung look like the liver itself. And we talked a lot about pleural effusions. And I gave you some nice images of really complicated loculated pleural effusions. So with all those things being said, I hope you enjoyed this lecture series when we talk about ultrasound. It is high yield, not only on the boards, but of course in clinical practice. And if you have any more questions, please feel free to get a hold of me. And how can you get a hold of me? Well, you can find me on Instagram and Twitter and Facebook and LinkedIn. And I wish you all the best on your journey.